block techniques. Okay. So these are the nodes that are supplying the sensory supply of our maxilla and mandible. It is maxillary and the mandibular, which is a branch of trigeminal nerve. Okay. So first we will learn about the maxillary nerve. Okay. So maxillary nerve, after it comes out from the trigeminal ganglion, it gives a meningeal branch, that is middle meningeal nerve within the cranium. Okay. And then it exits the base of the cranium by foramen rotundum. Okay. So once it exits from the rotundum, then it goes to the pterygopalatine fossa. Okay, it goes to the pterygopalatine fossa, where it again branches. There it gives a branch, that is one branch is posterior superior alveolar nerve. Okay, posterior superior alveolar nerve, and the next one is the zygomatic branch, zygomatic nerve, which goes here and supplies the zygomatic facial and zygomatic temporal. Okay, from there it goes here temporal and facial. Next it gives posterior superior alveolar nerve, and the other branches are pharyngeal branch, palatal branches. Palatal branches are like nasopalatine, greater palatine, lesser palatine branches, and orbital branches it gives. Okay, and once it finishes from the pterygopalatine fossa, it goes, the posterior superior nerve goes behind the maxilla. Okay, and enters the maxilla from posterior part of the maxilla. Okay, posterior superior nerve which enters the posterior part of the maxilla, comes to the posterior part of the maxilla, enters the maxilla from the posterior part. Okay, this is very important. That's how the posterior superior nerve block is given. We should know where is the nerve. According to that, the landmarks and this has been given. Okay, and after that it goes into the inferior orbital fissure, enters the orbital cavity, goes to the infraorbital groove. Okay, it goes into the infraorbital groove and canal, and within the groove and canal it gives out two branches, that is the anterior superior alveolar nerve and middle superior alveolar nerve. Okay, and then the maxilla exits from the infraorbital foramen. This is the infraorbital foramen, exits from the infraorbital foramen and comes out as an infraorbital nerve. Okay, infraorbital nerve, which is only a soft tissue branches. It gives out three branches to infraorbital nerve, that is superior labial, inferior palpebral and lateral part of the nose, but only the soft tissue, no hard tissue. Okay, anterior middle superior alveolar nerve is going to supply the hard tissue, that is the bone and the tooth. I mean the dendroalveolar segment. It supplies the dendroalveolar segment from the anterior, from the central incisors to the premolar. Okay, and maybe the mesial-buccal root of the first molar. The posterior superior alveolar nerve is going to supply the bone and the tooth, that is the dendroalveolar segment, from the last molar to the first molar, and maybe it will not involve the mesial-buccal root. Some 70 to that percentage is there. Okay, so that's how the maxillary nerve that will supply. So we need only three nerves which we give a nerve blocks are. One is anterior superior nerve block, middle superior nerve block, posterior superior nerve block, which takes over the whole dendroalveolar segment in the maxilla of one quadrant. Okay, so once you know all these three, the buccal part of and the bone and the alveolar segment is covered. The palatal tissue, only the soft tissue, palatal tissue, is been supplied by either the greater palatine nerve or the nasopalatine nerve. Okay, nasopalatine nerve from canine to canine, which is only a single foramen. Greater palatine foramen, this is the nasopalatine foramen. Okay, only one which supplies from canine to canine, and then you can see the posterior, this greater palatine foramen which is paired. There are two foramen which supplies the rest of the palatal tissue up to the soft tissue. The soft tissue is again supplied by the lesser palatine nerve. Okay, this is the basic of the nerve supply, means the branches of maxillary nerve and how it goes. This is the course which you should know. Depending on that, you will give your nerve blocks. You should change your nerve blocks. Okay, so first you will go with an infraorbital nerve block or anterior superior alveolar nerve block. Okay, which should involve the anesthesia of both the anterior and the middle superior alveolar nerve block. Okay, so now your landmark should be on the target area. When you are going to push your solution, your target at the tip of the needle should be on the outside the infraorbital foramen. It should be outside the infraorbital foramen. Okay, so how do you find out the infraorbital foramen? Okay, notch, infraorbital notch. Where is that? How do you? Yeah. So I'll just tell you that the infraorbital foramen usually it lies in the line of the supraorbital foramen over here and the mental foramen. If you take out the mandible over here, it almost lays in the line of mental foramen, the infraorbital foramen, supraorbital foramen, and the your pupil of your eyes. If you don't have any squint or anything of that sort, if it is normal, the pupil of the eyes and all these come in a straight line, almost in a straight line. So in this, you can take the pupil of the eye, you make the patient sit upright, ask the patient to look straight, take the pupil of eye. If he doesn't have any squint or any other deformities in the eye, you can, or telecanthus or any other deformity, patient not having any deformities, you can take the pupil of eye as a landmark or a confirmation point. And once you take the pupil of eye, you see the patient, take the pupil of eye, you can see the infraorbital rim, okay, which is a concave or a projection which you can feel. From there, once you come down, you can feel a depression, a concavity or a depression, where you can feel the infraorbital foramen. Okay, so one of your fingers should be on the infraorbital foramen. You can keep your one finger on the infraorbital foramen. You can pull the lip, okay, and keep one hand over there, pull the lip, and you take out the solution, you pierce it through the which area. There are two areas which you can pierce it. One is from the central incisor, another is first premolar, okay, and you prefer the first premolar because the distance between the distance that needle is going to travel is very short. If you go from your premolar, from central incisor, it's like a diagonal, it's like a triangle, you draw like this, it's a diagonal. More distance it should be covered by the needle, which is more painful for the patient, like more distance you pierce the patient, and the chances of making a small errors is also better, okay. So once you take it from the premolar, you go straight, you will end up over here, okay, you'll end up over here in this one. You should feel the bone, and the bevel of your needle should be towards the bone, not towards the soft tissue, okay, it should be towards the bone. And you go and stop it over in front of your foramen, aspirate in two planes, see that there is a negative aspiration, and you inject the solution over there. So once you inject the solution over there, you can feel the fill up with your finger which you have kept it over here, okay. Once you do that, once you finish pushing out the full solution, you take out the needle, you press over here, you give a pressure over here, okay, you give a pressure over here. You know why? Because we need the anesthesia of anterior and middle superior alveolar nerve, which is not outside, it is within the infraorbital groove or canal, okay. So the solution should go inside the foramen and get this anterior middle superior nerve should get anesthetized. So you give a pressure so that this goes inside. Here the mistakes what you do is, if you are not to the bone and if you are in the soft tissue, you will feel the fullness, but it will be within the soft tissue, and you press it, it doesn't go inside. Patient will have infraorbital nerve block. If infraorbital nerve paresthesia will be there, means anesthesia will be there, patient will feel full numb, but once you touch the patient, he will have pain, because the anterior middle superior nerve is not anesthetized, because the solution is within this one. That's why I told you should feel the bone over there, aspirate it and fill it over there, and once it goes inside, you can get an anterior middle superior alveolar nerve block, okay, and you should press it and you will do that, okay. And next is the nasopalatal nerve block. Nasopalatal nerve block, the nasopalatal foramen is our target area, and it is usually situated between the central incisor and the palatal region, okay. You can see the incisive papilla, don't pierce straight in the midline, pierce from the side, you just go, you should follow the curvature of your palate. If it is a shallow palate, you should go accordingly, and if it is a very high arch palate, your angulation should go parallel to the palatal wall, okay. So that's how you give a nasopalatal. Once you run, the palatal anesthesias are very painful. The palatal anesthesias are very painful. You know why? Yeah. Pressure. Yeah. The pressure build up over there is going to give you a pain. So once you fill the solution, there is no, the tissue is completely adherent to the bone, that it gives a very high pressure and patient will have severe pain. The other blocks are not in a very adherent, it is in a space, okay, it's in the canine space. Patient not going, he'll have pain, but when you compare with the palatal tissue, it is very less, okay. So You just give it some drops is more than enough for a nasopalatal nerve block. Okay, and once you inject, you just inject and once you withdraw it. While withdrawing, you should be pushing the solution and then only withdraw. Then not one injection take it out completely. While you're relieving it, when you're taking it back, you should go on pushing the solution, drop by drop, deposit the solution and come back. Okay, this is how you give a nasopalatal nerve blocks. Okay, and the posterior superior nerve block, as I said, this is this is mucobuccal fold of second molar. Mucobuccal fold of second molar is the place where you put your needle. Enter this one, okay, and then the zygomatic process of maxilla, and the maxillary tuberosity. These are your landmarks. Okay, so how do you inject it? So I think this. So before this one enters the posterior part of the maxilla. Once it enters the maxilla, then you can't get that once. Okay, so before it entering the maxilla, you should go and deposit over. It should come over here before it enters the maxilla. Okay, so your needle should come up to here. So in your patient, you can't just go like this. No? In this skull, you can always go like this, but in patient, you can't go there. So for that, they are given the technique. Okay, so it is always the upward, inward, and backward direction. Okay, so upward is again you should go to the mesiobuccal cusp of the first molar. The needle should go like it mesiobuccal cusp of first molar, go up to the root of second molar. That should be your angulation. Okay, mesiobuccal root of first molar. Think this is first molar, mesiobuccal root of first molar to the root of your second molar. Okay, so this upward and inward 45-degree angulation to the the occlusal plane. Okay, and then once you go there, then you should, the solution is still here. It has not gone to this area. It should go to this region. Pterygopalatine fossa region forum. So once what you do is you put it over here, and then it is 45-degree angulation to the long axis of your second molar. Okay, you think this is second molar, it should be long axis. You turn, your handle should go laterally so that your tip will go medially. You got it? Your handle will go laterally towards the buccal cheek, towards cheek region it goes, and so that the needle will go medially and go to the posterior part of your maxilla where you can deposit your solution. Okay, and the greater palatal nerve blockers, as you said, this is the greater palatal foramen. Okay, greater palatal foramen. This greater palatal foramen, if you define the foramen, it is like in the junction of alveolar process and the palatal process. This is the alveolar process, this is the palatal process, it is the junction of it between the second and third molar. Okay, so how do you detect that? You palpate the hard palate, go posteriorly, you will feel a depression, you will feel a softening where between the first and the second molar, posterior to the second molar. Okay, there you can feel a foramen. Just again it is little bit painful. Just inject it, just drop some 2 or 3 drops of solution and you withdraw this. Okay, if you know this much blocks, you can completely anesthetize the maxillary part and you can go for removal of the thing. Okay, and there is a maxillary nerve block where you completely block the maxillary. Now one is you go the same thing like posterior superior nerve block, you go more around 25 millimeters. You go more posterior, you will reach the maxillary nerve. In the pterygopalatine, where it divides into posterior, superior nerve, zygomatic branch and pterygopalatine, there you go, inject it, complete maxillary nerve block is going. One more technique is from the greater palatal foramen, you can go straight upwards, where again it goes and blocks the complete maxillary nerve block. This is which I said was posterior superior, and the complete maxillary nerve block is going to take place in that. So these are the nerve blocks. This I'll just demonstrate on the patient. Okay. So we are going to see, you are look straight. Okay, so we are going to look straight, take the pupil of eye as a guidance. Okay, from the pupil you go down, you can see this one, and once you go down you can see the depression and you can see the foramen over here, which I said. Okay, your finger is over here. Okay, and open your mouth completely, complete open, retract the cheek like this. Okay, retract the cheek like this. You are going to inject it over here. This is shorter distance. Okay, from here also you can inject like this. This is the shortest distance. You inject it over here, straight away it is going to go, and you feel the pressure over here. Give the solution. Once you give the solution with the same finger, you just start giving a compression over here. Okay, this is the infraorbital nerve block, or mainly it is the anterior and middle superior alveolar nerve block. Okay, and the middle superior alveolar nerve block, more commonly you can give in the just top to the premolars. There also you can go and give it like an infiltration block. You can give it an infiltration block where most of the times even your middle superior nerve blocks takes action. Okay, you know why? Because the maxilla is not like mandible; it is more porous. Okay, so you can give infiltration also works more better in maxilla than mandible in infiltration blocks, because maxilla bone is more porous than mandible. Mandible has all the cortical plates. Buccal cortical plate. In the buccal cortical plate, you have an outer cortical plate, inner cortical plate. Lingual plate, you have an outer inner cortical plate and inner cortical plate, and then the medullary. All these things are there. So there the block works, and here even the infiltration works. Okay. Go for a posterior nerve block. You retract the cheek. You go with the mesio-buccal cusp. You go straight to the root of the second molar. Once you go inside, upward, inward, go to the lateral, and then go inside. Again, you aspirate it, and most commonly you should aspirate it in two planes, and most commonly the posterior superior nerve block, because there is a pterygoid plexus of veins and also the posterior superior alveolar artery, which if it bleeds, it can cause an hematoma, which is a common complication of your posterior superior nerve block. So you always do a two plane aspiration and then inject the solution. Okay. So, and always in all your blocks, you should see that your bevel is towards the bone for better action. Okay, and this is the two buccal side, the bone and the dendritic segment is taken care of all these two blocks. And then coming to the palatal part, that's tissue, you go straight. Okay, according to this, from the incisive papilla, you go according to the parallel to the palatal vault. Palatal parallel, you go inside. If you get in the obstruction very soon, that means you are not gone into the foramen, you are still in the palatal bone. So change your angulation, go according to the wall parallel to it. It will go inside the foramen, you just aspirate and you can give it. And if you go for a palatal, greater palatal, open your mouth. Okay, you can go from the hard palate region, you go posteriorly, you will feel a depression between the second and the third molar, go straight, aspirate it, and you can give. There is a greater palatine foramen. Okay, where you given greater palatine nerve block. Okay, so these are the maxillary nerve blocks. Okay, the inferior nerve, it comes out from the posterior division. It goes and enters the medial part of the mandible in a foramen. Okay, this is a tongue-like projection that you can see in that foramen. That is called as lingula. Okay, this tongue-like projection that is called as lingula, and this is the mandibular foramen. Okay, this is the mandibular foramen. In the mandibular, it enters the mandibular foramen from the medial side. It goes into the canal, that is the inferior alveolar canal. You see an impaction, when you see the impaction or something, we say there can be chance of inferior alveolar nerve injury because the canal is near the tooth. So this is the canal that goes along the medial surface, and most commonly it goes below the root of 7. It takes a crossover from the medial to the lateral. It takes a crossover, goes to the buccal part and comes out to the Mendel foramen. Okay, it comes out through the Mendel foramen as Mendel nerve. Okay, Mendel nerve is again a soft tissue supply. Okay, there is no hard tissue supply. After that, the inferior nerve goes forward up to the midline as incisive grounds. Okay, and before this goes into the canal, it gives a myloid branches, myloid nerves and vessel, gives a myloid nerve vessel which goes and supplies the myloid muscle. Okay, so you should know this much. So now your target area is to inferior nerve is going to supply the whole mandible. The whole mandible is going to supply the whole mandible and the tooth, dental alveolar segment, tooth and the mandible from the posterior part to the midline. Okay, and also the soft tissue from the anterior part of your Mendel foramen. Soft tissue from the anterior part of your Mendel foramen supplies the inferior nerve supplies. The posterior part, or maybe up to the mesial surface of your first molar, the long buccal nerve supplies. Only the mucoperiosteum, not the bone. Only the mucoperiosteum is supplied by the long buccal nerve. Okay. So when you take an inferior nerve block, first you should know this is the anterior part of ramus of mandible. Anterior part of ramus of mandible. Okay. The anterior part of ramus of mandible, there is the deepest point in the anterior part of ramus of mandible which is known as coronoid notch. Okay. The importance of this coronoid notch is this is the guidance for your usually anatomically most commonly the coronoid notch is in the same line of your mandibular foramen. Okay, mandibular foramen. So if you take the landmark, you palpate the anterior part of the ramus of mandible. You can go to an external oblique ridge, you can get over here, and you can see the internal oblique ridge. The triangular space which you see over here is the retromolar triangle. Okay, so once you feel this, you cover this retromolar triangle, you can get a bit of the buccal pad of fat which is supplied there. You can feel the buccal pad of fat also there. Okay, so once you feel that, you can retract the, keep in the coronoid notch, retract the whole thing, keep the finger over here. You bisect the finger and you should reach the mandibular foramen. So anything from the midline, the bisecting line of your thumb, anything from the above the midline of this is okay. Anything below this, you won't have an anesthesia. Means before the nerve entering the canal, you should give the supply. So if you give a solution over below the canal, you are not going to anesthetize the inferior ulnar nerve. Maybe the myeloid nerves may get anesthesia, but not the inferior ulnar nerve. So always it should be above the mandibular foramen. So yes, top of it and go. You take it from the opposite side. You also usually take it from the opposite side, the premolar region. Okay. Once you just keep it like this, you keep this. Take it from the opposite region, bisect this, and go and you should give it over here. Okay. The target area will be this. Okay. From the premolar, target area will be this. Okay. Now, if you don't get this bony resistance, the only nerve block where you should feel the bony resistance is inferior alveolar nerve block. Okay, because once you don't get the bony, this one, either you will get an early bony resistance where again you are in the wrong place. Okay, you are in the wrong place, or else you won't get a bony resistance. If you don't get a bony resistance, that means you are going more posteriorly. If you are going more posteriorly, what will happen? Parotid gland is usually in the lateral part. It is over here, but it is almost like this. Okay, the deeper lobe is most posterior to this one, it is the deeper lobe. Okay, so once you don't get a bony resistance, you are going to inject a solution to the parotid gland. Okay, once you inject to the parotid gland, the facial nerve is going to get anesthetized. So you will see a temporary facial nerve weakness, which once the LA effect is gone, will get alright, but again you will have a temporary or transient facial nerve paralysis. Okay, so that is a reason where you should get a bony resistance to know that you are in the right position above the mandibular canal. Okay, that is one nerve block. Next one is your long buccal nerve. Long buccal nerve, it is from here, it transfers to the buccal region over here. From here it supplies the whole the mucoperiosteum up to the first molar. So again the block you give is distal to the last molar. Distal to the last molar, you give an injection and just apply pressure the long buccal nerve. Maybe the mucoperiosteum up to the first molar is anesthetized. Okay. Next is the Mendel nerve block. Mendel nerve block, again, like once you give an inferior nerve block, still patient is having pain in the buccal side. Maybe you can give a Mendel nerve block. That is again like an infiltration block. You go straight below the mandibular for premolar down and just inject it. You will get the Mendel nerve block. Next is incisive nerve block. Incisive nerve block, again you should be very careful. As I said, incisive nerve block doesn't come outside. From inside it goes through the canal, within inside goes into the up to the anterior it goes. So what you do is you angulate the needle from your anterior part. You angulate it there. Your bevel should be towards the bone. You go up to here, start injecting and pull the syringe backwards. You should be injecting and inject the solution and pull back. And once you inject and finish it, you give a pressure over here, so that your bevel should be towards bone and this should be an angulation. You can see the angulation of your foramen. It is more towards like this. So your bevel should be towards the bone and should be in this angulation. Push on your solution, slowly withdraw. While withdrawing also you should be pushing your solution. Once you come back, the solution will be filled over here. Give pressure, it will go inside the foramen and your incisive nerve block starts working. So once you know all these blocks, you can completely block the mandibular. Okay, and there are two techniques for mandibular nerve block, that is a Gauge and Wasseroni-Akinosi method. Okay, Gauge is like a mandibular nerve block where you open mouth technique. It is a completely open mouth technique. Maybe your inferior on the pterygomandibular space, there is some infection in the pterygomandibular space where you give an inferior nerve block is given in the pterygomandibular space. Okay. So once you have any infection or any problem in the pterygomandibular space and your inferior nerve is not getting acted or it's not getting completely, you can give a mandibular nerve block where you give straight away to the almost to the condyle region. Okay, is that you ask the patient to wide open the mouth, and if the patient is able to do a wide opening, you ask the patient to wide open the mouth, and the mesiolingual cusp of the last molar or the second molar, you go from the opposite side, from the mesiolingual cusp of the upper second molar, you follow that straight away, you go, you will get a bony resident. Mostly it will be on the condyle. Okay, and where you inject the solution, you get a mandibular nerve. The whole thing is going to get anesthetized, and that is like you keep the mandible straight open like this, maximum open like this, and just go on. So when you wide open, your mandible, the condyle is going to come little more downwards. So anterior and downwards. So you can inject to the condyle. Patient is not able to open the mouth; it's closed completely. You need to give a mandibular nerve block. You give a maxillary acinosis method. That is, you follow the mucogingival junction, you follow parallel to that, you just go straight, maximum posterior, around 16 to 25 mm. You go back, you will reach here. See, you can inject over here. Here you don't get an bony resistance. You just go here and you inject there the maxillary acinosis method. Okay. So this is the premolar. You go from the opposite side premolar. You go straight. You can feel the anterior part of ramus of mandible. From the above, you should come down. You get the deepest point. See, okay. See, this is the deepest point. This is the coronoid notch. Okay. This you see a line over. This imaginary line which you can see here is the pterygomandibular raphe. Okay. So you open your mouth wide open. Yeah. You bisect this, and anything above that is fine. You go like this. Pierce it over here. You go back. You get a bony resistance. Withdraw a bit, withdraw 1 millimeter, because you bone straight on the bone, it will be more painful. You can withdraw just 1 millimeter, just relieve it, and then you aspirate and give the solution. Okay. And for some patients, the mandibular angle means there will be more divergence of the mandible. Okay. So that it will be more divergence. So this mandible is going to go this side. So once you go, you may not get a bony resistance. Okay. So for that, you can use the Fisher 1, 2, 3 technique. Okay, Fisher 1, 2, 3 technique is you go on the almost on the anterior part. This is the anterior part. You inject there. That is the like that almost in the external oblique ridge. Okay, almost there. You give a bit or 2 drops of solution. Withdraw a little bit. Come towards the same side. You go inside. Aspirate and give the lingual nerve block first. Lingual nerve block first, and then you go this side, and then you can go. If there is a nice divergence of the mandibular angle, also you can get the bony resistance. Okay. So the inferior nerve technique also, once you give inferior nerve block, you withdraw off, and also you can push off your solution for giving a lingual nerve, because lingual nerve is more medial to the inferior. One more technique is you withdraw a little bit, go to the same side. You can go 1 or 2 millimeter again inside, and also you can deposit for a lingual nerve block. Okay. Mental nerve block, as we said, it is straight away below the 2 premolars. You just go down and give. And if you are giving an incisive nerve block, you take an angulation from canine. From canine, bevel towards the bone. Go straight away, still below the lower bone. You can feel this aspect. As you withdraw, you deposit the solution. Withdraw, deposit the solution properly, come and give pressure over here. Okay. And for the Gauge, you open wide open, and then give it to the mesiolingual cusp of the second molar. You go over there. Maxillary acinosis, close your mouth. Patient can't open the mouth. So go straight parallel to this. You go maximum 16 to 15 straight away. You go like this. You won't get any bony resistance. Aspirate, you can give it. Okay. LA with adrenaline, any part of your body, you can aspirate. Even if it is a negative aspiration, you can give it. Only in the tip of your body, where it is end arteries, where because of the adrenaline, you can cause an vasoconstriction and the necrosis of that area. Other than any area, you can give an LA with negative aspiration. Only the end arteries area, like nasal tip of your, to all this are end arteries. There are no other blood supply. If there is a vasoconstriction, there is no other blood supply. There are chances of getting it necrosis. So any other area, you can safely, if it is negative aspiration, you can give.